like to introduce our next speaker. It is my pleasure to introduce Dimitrios Dovas. He is the infertility specialist, medical director of Newlife IVF Greece Center of Reproductive Medicine. He is also on the Greek Board of Obstetrics and Gynecology.
All right, good morning everybody. I'm thrilled being here for 3 reasons. The first one is because I'm going to have the chance to meet some friends. Thanks Aji for inviting us here. And also get through these magnificent scientific sessions. The second thing is because I'm addressing to a female audience, mainly nurses. This is the reason I've chosen to become an OBS/GYN, because I love working with women. In our IVF unit, it's only myself and another male who actually is a doctor. All the rest of the staff, embryologists, nurses, administrative staff, they're all females and they're looking after us. And the third thing I'm such happy for today's event is because you're so many guys. The last time I had a presentation at 8:30, there were only 4 people in the audience. 2 of them was my wife and my son. So thank you for being here. Today, we're going to speak about, like Angie said, different protocols and mainly how we inhibit the LH surge in order to have the follicles ready for aspiration. So I'm going to give you some theoretical background and also I'm going to present you some studies. I don't want you to remember the details. I'm just going to show you how you read the studies and what you need to take home. So, this would be the ideal scenario. Have 1 egg, get 1 sperm, fertilize it, create 1 embryo, culture the embryo, possibly to the blastocyst stage, put it back, you get the woman pregnant. Maybe someday we'll get there, but not quite yet. So, we need to have more eggs, and that's why we need to stimulate the ovaries. Why is that? Because some of the follicles we see on the ultrasound during the stimulation phase are empty when we aspirate them. Some of the eggs that we get are not M2, metaphase 2, like Angie said, so they're immature and cannot be fertilized. Even some of the M2 eggs are not fertilized. Some of the embryos, the fertilized eggs, do not develop during the culture in the lab. And maybe some of the embryos that do develop are not of good quality, with fragmentation, like Dr. Berto said, so they're not ideal to be transferred and give a pregnancy. So this is why we need to stimulate the ovaries, because the end point is to have top quality embryos, and in order to achieve this, you need more eggs. So how many eggs do we really need in order to get there? Well, this is a study from the United Kingdom. They searched all the registry from the HFEA, which is the regulatory authority in the UK. And actually what they found out is that you get better results when you get about, what is that? Hold on. Got it. So when you get about 15 eggs. I think it's a little bit too much. I don't know what happens in the units you work, but usually we don't get 15 eggs. Usually we work with smaller numbers. But I think the reason for this in the UK is the fact that usually they fertilize the eggs with plain IVF and not with fixing. So as a result, they end up having lower fertilization rates, and this is why they're more aggressive with their stimulations. These results apply to every age group. So as you can see, in age groups from 18 to 34, 34 to 37, 38 to 39, even in women older than 40, usually this is the number that is the ideal in order to get the better pregnancy rates. So the IVF programs have 2 main key components. The first one is obviously the ovarian stimulation. So apart from the stimulation with tablets like the clomiphene citrate or letrozole, the aromatase inhibitors, usually for IVF programs we use injectables. So the 2 main categories of the gonadotrophins we use are either the recombinant or the urinary. Conflicting statistics regarding success rate, but generally it seems to be equal. There's the long-acting FSH, which makes the whole treatment more friendly. This means that the woman has to inject herself once in the beginning of the treatment, and this is actually a depot injection, so the drug is slowly released for the next 7 days, and about 30% of women do not need any additional FSH following day 7. Short-acting is the one we usually employ, the daily injections. And obviously the need for additional LH, because there are some studies supporting that specific age groups like older women or poor responders might be benefited if they get additional LH. The second key component, and the main area of my talk today, is about how we avoid the LH surge, and obviously how we avoid ovulation, because we want the follicles to be intact for aspiration. So there are 2 ways to do this. The first one is by using the GnRH agonists or GnRH analogs, or the GnRH antagonists, which are, like Dr. Belzo said, more commonly used nowadays. Well, this is actually the form of action. I'll start with the antagonist because it is easier. So what the antagonist does is that the day we start supplementing the woman with the antagonist, it just switches off this area in the pituitary, so no LH and no FSH is further produced. Whereas with the agonist, initially the first few days that we give the medication, the pituitary works harder, so it produces more FSH and LH, and this is why we use it in the so-called short or ultra-short protocols to take advantage of this initial action. But following a few days of administration, due to the negative feedback effect, it switches off the pituitary, and that's why we avoid the LH surge. So this is the way of action. I'm not going to go into details regarding the proteins they have, in which places they differ, and so on. But what we need to know is that these are the main differences. The antagonist, the onset of action is immediate. So the duration of treatment is considerably shorter. Like I said, with the agonist, we need long pretreatment, particularly in the so-called long protocols, either the mid-luteal or the follicular phase long protocol. The woman needs to be on the agonist for at least 7 to 14 days, which is a long period of time. And usually, during this period, she might get estrogen withdrawal symptoms, like vasomotor symptoms, hot flashes, night sweats, and so on, because the ovaries switch off. Obviously, we do not get these symptoms with the antagonist. Another important difference is that the pituitary recovers at once following the antagonist administration. When I say at once, I mean within 30 hours. So if for some reason the egg collection will not be performed in the next 30 hours, it's very likely that this woman is going to ovulate. The recovery of the pituitary takes much longer with the analog, the GnRH agonist protocol. So it might take up to 2 weeks for the pituitary to recover. Well, these are the different protocols we use. I'm sure you're pretty familiar with all of those. The ultra-short protocol, like I said, uses the GnRH agonist in the beginning of the cycle in order to stimulate the FSH production. And then we carry on with externally administered FSH to mature and develop the follicles further. And obviously we trigger maturation at some point when the follicles reach the criteria for the aspiration, usually when the dominant 1, 2, or 3 reach the size of 18 millimeters. With the short protocol, we start again with the GnRH agonist in order to trigger production of pituitary FSH, and at some point when the negative feedback mechanism starts to work, we add externally more FSH and we carry on with the agonist in order to avoid premature ovulation. With the long protocol, we pre-medicate from the previous cycle, usually about a week prior to the anticipated period, in order to downregulate the ovaries, make sure that the woman is in a menopausal state, so very low levels of estrogen. Her period will come, make sure that the lining is very thin in order to start the stimulation. This is usually the period of time they get problems with the vasomotor symptoms. Sorry, that was the second one, the long mid-luteal. The long follicular obviously is exactly the same. It's only the fact that usually takes shorter for the ovaries to be downregulated. And the Antagonist protocol, as you can see, it's a very short one. Many people in the world call it a short protocol, so we get confused with the second one. We start straight, there are certain criteria when we start with FSH. We start straight with FSH administration, and at some point we initiate the Antagonist in order to keep the follicles intact for the egg collection. So this Cochrane guy, Archie Cochrane, was, I think he was a physician from the United Kingdom, and at some point around the 60s, he saw that there were conflicting practices throughout the United Kingdom for the similar diseases because there were no randomized trials, no good evidence to support what we should or what we shouldn't do. So most of the people, the practices they were following have mainly to do with their experience and not with the experience of their other colleagues. So he started doing what we say nowadays, the meta-analysis. He started collecting data about the same subject from different scientists in order to make the conclusions more robust, more strong. So nowadays, Cochrane Library, the database of systematic reviews, is considered the most accurate way to get information about the efficacy of any intervention. This review was actually published quite recently in 2015 and compares what happens if we start comparing the different agonist protocols, like I showed you, the short, the ultra short, the long. So what are the conclusions? This is what I hate in medicine, when we have so many numbers and we don't know, how to get a conclusion from these things. So I'll just show you what you need to watch. This axis here, this line, is the most important thing in this diagram. So all the measurements we get from this side favors one of the interventions. So in this case, this is the short protocol. If we get results on this side of the axis, they favor the other intervention. In this particular slide, the long protocol. You've heard many times about statistical significance. What does it mean? It means that the end result, this diamond here, should not cross the line. So if the result crosses the line, the conclusion is not statistically significant. So let's see how we get it now. In this review, they compared the long versus the short agonist protocol in IVF. So the first thing they tested was the live birth rate, and as you can see, it seems to favor a little bit the long protocol, but not statistically significant because it crosses the line. If you look at this line, it says that the odds ratio, the OR, is 1.6, so it is larger than 1, it favors this side, but the range is between 0.85 to 303, so it crosses the line of the 1. It's not statistically significant. So every time we get a result that is not statistically significant, we cannot use it in our practice. The same applies to the ongoing pregnancy. Usually when we're talking about ongoing pregnancies, we're talking about pregnancies that reach the 12th week. So again, the results seem to be a little bit more towards the long protocol, but again, because it crosses the line, it's not statistically significant. And obviously, the same applies to the final conclusion. What happens if we compare the long versus the short protocol regarding the clinical pregnancies, which means see pregnancy on ultrasound, we may detect fetal heartbeat? Well, in this case, we get slightly better results with the long protocol. Because as you can see, the final result is 107 to 179, so it doesn't cross the line, it's more significant. Again, it's not a huge difference, slightly better than long protocol. This applies both to non-selected population and it's more evident with poor responders. So the final result seems that regarding clinical pregnancy rates, maybe the long protocol is a little bit better. What we're looking at mainly in fertility treatments is the live birth rate. This is the most important parameter in order to see if a treatment is efficient or not. So regarding live birth rates, they're exactly the same. So what happens with the antagonist? As I told you earlier that we initiate them at some point during the stimulation, but at which phase of the stimulation do we do it? Actually, there are two practices. The first one is the so-called fixed protocol. This means that whatever the picture we're going to get from the scan, or maybe from the estradiol levels, we're going to start the antagonist on day 5 or maybe day 6. Some other people start the antagonist when the leading follicle reaches the size of 14 millimeters. It doesn't make any difference. You get exactly the same results. Obviously, with the second practice, you need to monitor the woman quite closer, because if during the first scan on day 5, the leading follicles are around 10, 11, you don't know when the leading one is going to get the size of 14. So it's better, according to my view, to go with a fixed protocol. Sorry guys. Well, this is a paper at Human Reproduction when there was a huge debate in the early middle 2005, 2006 about the antagonists, their results, if they're good enough or not. So this paper came from Professor De Vrooy from Netherlands, which actually gave the directions on how we use the antagonists. There are certain criteria. Obviously, they did that in the ideal population. So as you can see, these women were regular IVF patients with 5 to 9 antral follicles per ovary. They weighed less than 35, no PCOS, no history of poor response, no endometriosis. But again, this is the ideal population if you need to test a medication or a treatment. Criteria to start treatment: day 2, perform a scan. Obviously, on day 2, the woman is menstruating, so you need to make sure that the lining is thin. Usually, you need to get an endometrial lining less than 5 millimeters. And also, make sure that there's no follicle larger than 12 millimeters. Once we get this criteria, you start with the FSH stimulation. On day 5 to 6, you start the antagonist, so this is the fixed protocol, and then you carry on monitoring either just with ultrasound or with blood test to check the estradiol levels in order to get the criteria. Actually, in this paper, they state that you need to have 3 follicles between 15 to 19 millimeters. In our unit, we do not monitor the women with estrogen. We just rely on the ultrasound parameters, because there's some evidence that during the antagonist protocols, the estrogen levels are falsely lower than they should be, so you don't get a very good picture of how it goes. Again, this guy Cochrane, this is a systematic review about the efficacy of the antagonists. It's quite interesting that the guy who's responsible for the review, it's Professor Al-Minani from Egypt. He was totally against the antagonists. So when first the antagonists came and people started using them, there was a huge debate between Egypt and this guy, and Netherlands and Greece with another guy who works with the antagonists. The initial results were disappointing. The antagonists were not doing well at all. Very low pregnancy rates, so people were starting considering if this was or it should be the drug of choice. Time passed, and now Professor Al-Minani made the review for the antagonist, and she was surprised to see that now it shows that it's exactly the same with the agonist. So in terms of live birth rate, although it slightly favors the agonist, like we said earlier, it crosses the line. The result is 0.86 between 0.69 and 1.08, so it's exactly the same. The same applies to subgroups in women with minimal stimulation or with different type of antagonists, ganirelix or cetrorelix. So in terms of live birth rates, agonist and antagonist protocols give exactly the same pregnancy rates. This is a message to take home. What happens with the ongoing pregnancy rate? Well, Like I said, it's too complicated, so this is what we need to see, that although it's just on the edge of the statistical significance, again, it seems that we get the same result. Obviously, like you see here, the same applies to subgroups, women with PCOS or poor responders, and also the same applies with miscarriage rates. We get exactly similar miscarriage rates between agonist and antagonist protocols. And here is the important thing. As you can see with the antagonist protocols, we have a very, very significant reduction in OHSS. This is very important. Nowadays, a modern IVF clinic should be OHSS free. I don't think it's a good medical practice anymore to have women who get hyperstimulated. There are many ways we can avoid it. I'll tell you a few things later on, but this is very important. This actually has changed our practice on what we do with donors, on what we do with women who decide to vitrify their eggs for future use. So this was a very, very important conclusion of this meta-analysis. Again, cycle cancellation. Well, it seems that with the agonists, we get more cancellations than we get with agonists. With antagonists. What is the main reason? Well, the risk of HSS. So we had to cancel many treatment cycles with GnRH agonists when we saw that the ovaries started being overstimulated. We performed the costing. We just never gave the HCG to trigger maturation. So this is the main reason we get more cancellations with the agonist. In all studies in IVF, you must be very, very careful to avoid bias. And the second result, I think, is due to bias. It says that the cancellation is due to poor response is more common with the agonist. Well, yes, it does happen, but most of the people, when they have poor responders, they give GnRH agonist protocols. So I don't think it's a very clear conclusion. So how are we going to choose between agonist and antagonist? Well, the first thing obviously is success rates, and like I said, it doesn't make any difference. OHSS risk, it's very important. If I have a group of women who are at high risk of developing OHSS, like PCOS women, or women with the so-called PCON, so not the classical syndrome, but the polycystic morphology of the ovaries, you should go for the antagonist. Gonadotrophin consumption. Well, there are studies showing that women who follow the GnRH agonist protocol need more gonadotrophins. So it's quite important in places where the state funds the medications. Cost effectiveness, you know, is one of the most important parameters nowadays when you are about to initiate the treatment. So you use more gonadotrophins with the agonist. Length of treatment, well, it was obvious. With the agonist, you get much longer treatment, so it's not as friendly as it should be, as it is with the antagonist. Cycle programming, well, it's a little bit dodgy. We doctors usually love to program the cycles, avoid weekends, avoid bank holidays. I don't agree with this because it's not a good practice, but it's a common problem, particularly in huge IVF units. They need to program the cycles. It's much easier to schedule treatment cycles with GnRH agonists. With GnRH antagonists, it's very, very difficult. Why is this? Because if you pre-treat with a pill, you end up having lower pregnancy rates or longer duration of the treatment. If you give progesterone, usually it has a negative impact on the endometrium in the subsequent cycle. There is a smart way in order to program cycles with the antagonist. If you give estrogen the last few days of the previous cycle, and when the period comes, instead of starting the antagonist on day 2 or 3, carry on with estrogen a few days and start the antagonist, the stimulation when you want to. So the best way to program cycles with the antagonist is by giving estrogen on the previous cycle. Again, I'm against programming, but I just had to say that to you. And obviously, like I said, specific groups of people needs to have specific treatment, antagonists obviously. And these women are women with PCOS, and like I said, all side donors, and in cases that we vitrify your side. So here is our practice. Actually, I'm the medical director in Newlife IVF Clinic. This is a private IVF unit in Greece. Usually, we run about 500 to 600 cycles per year. So we do have quite, an experience on how we deal with stimulation. About 80% of our treatment cycles are with antagonists. Obviously, we individualize treatment cycles, but since, like I said to you earlier, we don't have any significant difference in terms of pregnancy rate, usually we go with the antagonist, which is more friendly and more safe. By using the antagonist, you're very flexible when you're offering programs of natural cycle or modified cycle. Nowadays, many women have very poor ovarian reserve, so before you start treatment that they're not going to respond. They're going to produce only 1, maybe 2 follicles. In these women, it would be a waste of time and money to stimulate them because they're going to produce anyway 1 or 2 follicles. So you might end up going with a natural cycle. In that case, you need to avoid premature ovulation. You need to have the follicle intact to aspirate. So the antagonist is a nice solution. It acts rapidly. You can use it for a couple of 3 days, avoid ovulation, perform the egg collection. Obviously, the same applies to modified natural cycles. A modified natural cycle means that if I have a woman with a poor reserve, 1 or 2 follicles, AFC 1, 2, you know that there's small month-to-month variation in this AFC. So if in a subsequent month, see that the AFC of this month is 4 or 5, I might decide to give mild stimulation. This is a modified treatment cycle because we made the decision depending on what we see on the actual month. The antagonist is very, very important in these treatment cycles as well. Like I said, if programming, we need to give estrogen and not the contraceptive pill because pregnancy rates could be reduced with the pill and the length of stimulation is longer. One important observation is that if you have obese patients, usually we give the antagonist twice a day, so every 12 hours, because we had a few cases of premature ovulation in the antagonist groups in women who were obese. Obviously, the reason was that the amount of medication was not enough in order to inhibit ovulation. So this is our practice. Following a certain BMI, we give antagonist twice a day. Right. Absolute indication for antagonists. I told you that. Polycystic ovarian syndrome. Now, like Dr. Berto said, you're very, very flexible with the antagonist protocol. Why is that? If everything goes according to plan, you trigger maturation with HCG, you get your egg collection, you carry on with a fresh treatment cycle. If the woman starts being hyperstimulated, you have 2 options. The problem with the PCOS is that the window of minimal to hyperstimulation is very, very narrow. So with 100 units, the woman might produce 3 follicles, and with 120, 23. And you can never know beforehand if this is going to happen or not. So by following the antagonist protocol, if you notice that the woman is going towards hyperstimulation, you have 2 options. The first one is trigger maturation with the GnRH agonist and freeze all the embryos. That's the safest option. The second thing that we do is that in cases of that we do not anticipate a moderate or severe hyperstimulation, it depends on the number of the follicles, on the levels of estradiol and so on, we carry on with the fresh cycle. But what we do is that obviously we trigger maturation with the GnRH analog. On the day of the egg collection, we give either 1,000 or 1,500 units of HCG, depending on the body weight of the woman. And then we follow a very aggressive luteal support with estrogen and progesterone. There are studies showing, particularly from a Danish group, from Peter Humaidan, that by following this practice, you get equal pregnancy rates. So it's something we decided, I told you I like to individualize our treatments. So if we see that the worst case scenario would be a mild hyperstimulation, we might offer a fresh treatment cycle with a very aggressive luteal phase support. But obviously the antagonist is not the magic drug. There should be some cases that it's not the drug of choice. And according to the evidence and according to our experience, we shouldn't use the antagonist in women with endometriosis. There's evidence showing that if you follow a long Agonist protocol, we get better pregnancy rates. Well, the reason is obvious. This short period of downregulation suppresses any endometriotic spots that could be present in the pelvis, and you know that there is evidence showing that these spots producing substances that lower the dynamic of the eggs. So in women with endometriosis, we get lower egg quality, lower fertilization rate, and eventually lower embryo quality. So by doing a general Antagonist protocol, you end up having better eggs and better pregnancy rates. Also, we follow the Agonist protocols if during the assessment of a woman in the beginning of the cycle, we see that her antral follicles are unequal. So for example, if you scan a woman on day 2 or 3, and you see that each ovary has about 6, 7 follicles, 2 of them are 3 millimeters, and the others are 10 or 12. If you follow an Antagonist protocol, the cohort of the larger size will be ready with the next 3 or 4 days, and the small follicles will never catch them up. So you end up having a lower oocyte yield because you haven't programmed well your treatment. And this is why when we have asynchronous follicles, usually we follow the Agonist protocol. In most of the cases, we pre-treat them with a pill, so we slightly suppress them with the pill and then with the Agonist, and we get equal sized follicles and more eggs on ejaculation. So that's all. Thank you very much for your attention. I will be more than happy to answer any questions that you might have.
Thank you very much. That was really interesting. I'm interested in knowing whether you do mostly fresh transfers or mostly vitrification and freeze-roll. I may have missed that.
I would say it's about half and half. So it really depends on what we see when we're about to trigger maturation. Usually, if we see the so-called kissing ovaries, you know, the side ovaries large, side by side, or maybe they start getting some peritoneal fluid, usually go for freeze-roll. It's very interesting. Actually, your question is very, very interesting because there's some evidence recently, the last year, showing that with frozen embryo transfer cycles, you get better pregnancy rates compared to fresh embryo transfer cycles. And maybe you have lower chances of preterm delivery with frozen embryo transfer cycles. I think this has to do with the culture media we use, and maybe due to the fact that with ovarian stimulation, you make a hostile environment in the uterus for the embryos to be implanted. But this is the reason why we could move more towards the freeze-roll policy, because it seems from recent studies that you get better results with the frozen embryo transfers. It's interesting to let you know that with this approach, to decide if we freeze-roll or if we trigger maturation with the Agonist, give low dose of HCG and then high dose of estrogen and progesterone, we haven't had any moderate or severe HSS the last 5 years. And obviously no hospitalization.
Just as a quick follow-up, do you think that's going to change the agonist versus antagonist, the ratio of what you use? Do you think it's going to influence your talk today, for example, in a year if you're doing all freeze-rolls? Do you think the antagonist?
I think so. I think so.
Thank you so much for your interest. Can you please describe your aggressive luteal support? What exactly do you use?
Right. That's interesting as well. In Greece, we haven't had available subcutaneous progesterone. It's only came available the last 3 or 4 months. So we had to give progesterone in high doses. That's one thing. The ideal route of administration of progesterone during luteal support is either vaginal or intramuscular. Progesterone orally, because it goes through the liver, you end up having lower levels of progesterone in the target organ, which is the uterus. So you have either to use vaginal progesterone or injectables. The problem with injectables prior to the subcutaneous preparations is that they're oil-based. So they're very, very painful. Women end up having sometimes lumps, so they cannot even sit. So before the introduction of the subcutaneous progesterone, where we're giving them 600 to 800 milligrams of progesterone vaginally, and twice a week we were given 150 milligrams of hydroxycaproic progesterone, which is what we use. Nowadays, because of the subcutaneous progesterone that we have, we carry on with the vaginal route, so 600 to 800 milligrams vaginally, and we give them every other day 1 shot of subcutaneous progesterone. Now, with estrogen, it's a little bit bizarre. When we have a woman hyperstimulated, obviously you have high levels of estrogen. So why should you give additional estrogen? But yes, they do need to have additional estrogen. It's been proven from studies. Usually we give them around 2 to 4 milligrams of estrogen during the luteal phase. So this is the aggressive protocol. And like I said, we give them small doses of HCG, well actually 1 shot of HCG, because this is proven to make a huge difference. So on the day of the collection, if we have decided that we will go for a fresh cycle, we give them either, like I said, 1,000 or 1,500 units of HCG intramuscularly. This depends on their body weight and the looks of the ovaries. If we're afraid that the follicles are that many, usually we go with the 1,000. So, like I said, it's individualized. We do have the guideline, the standard procedures that we follow, but we individualize what we do on what we see on the day that we're about to trigger maturation.